So hopefully the pictures of the cows and the lighting sound didn't scare anybody. But this is what we're monitoring, and this is kind of why. Like, with the medication assisted treatments being an option, we have the MapBridge program here, and we have some of these things that can help. But we have to know what stage of withdrawal that they're in, because if we're going to treat with any kind of medication assisted treatment, they have to already be in the early to middle withdrawal. If they're still in the intoxication state, then we can put them into an abrupt withdrawal if we try one of these. So how does this all work in the brain? So the methadone, like as a treatment option, is a full agonist, meaning it binds up that whole receptor, right? So it works essentially, and this is why you see methadone even used for pain sometimes, for pain management. So if you have somebody that's in the hospital that maybe they are addicted to opiates, they're habituated to it, but they also are maybe going for surgery, or they have things, they have burn, they have wound or something we need to manage, we're probably not going to start them on something like Suboxone because it doesn't do as well for pain control. But methadone might be an option because it is a long lasting, and it binds up that whole receptor. For the bupropion, again, it's a partial agonist, so it binds some. So we can use it if there's like mild sort of pain issues, but also they want to be on a treatment. The naltrexone, again, it blocks the receptor itself, so nothing can get in. That's your Narcan. That's the reversal agent. So we want to be thinking about how much do they block, as it helps us guide like what might be appropriate for their treatment. These are the ones that have approval for treating opiate use disorder. So we have the methadone, which you talked about, which is used for maintenance, right? That and the bupropion they're both maintenance drugs, right? Naltrexone, the Vivitrol is kind of the injection that we can give for that. So all three of those are maintenance, meaning that we're not necessarily withdrawing someone off altogether, although we can use the maintenance drugs to slowly titrate them off. But these are meant to sort of be prescribed ongoing while they're in treatment. There's some restrictions depending on what type of medication we might be treating them for. What we're really kind of looking at the potential for the precipitated withdrawal being the highest in these either partial or full antagonists, right? So we want to make sure if we're utilizing that we're doing it at the right stage of treatment, so that we don't put someone into precipitated withdrawal, because they will not be. We're going to talk about agitation management, but if we overshoot and that happens, they are going to feel really bad and really quickly. So agitation is always a concern. So with the withdrawal timeline itself, again, from the time of the last dose, depends on if it's short or if it's longer acting, but about 72 hours is where we will see those middle to late symptoms peak. Now, that's not to say that the withdrawal is going to be over, but those are when the symptoms are kind of at their worst. So just like alcohol withdrawal, if we don't treat it, that 3-day turn is not fun. Opiate withdrawal, pretty much the same. That's usually when they're at the worst of it. At about 72 hours. After about a week, again, they still might have the tired, the body aches, anxiety, irritability, but it's, they're kind of passed over the hump, so to speak. Doesn't mean that they're comfortable at this point. As we get to like the second week, kind of through the end of the month, it's really more of that psychological and emotional symptoms. So now they're kind of having to live in a world raw. They don't have that substance numbing them out anymore. And so a lot of depression, anxiety, irritability can start to be more prominent. After about a month, they're kind of in maintenance, but it's about the cravings and the lifestyle change at that point.